Good morning everyone and welcome to today's webinar, Clinical Guideline for Diagnosis and Management of Work-Related Mental Health Conditions. I'm Stephanie Morawski from WorkSafe Tasmania and I will be your moderator today. Before we start, I ask that you take a few moments to read the following slide about information received today. I will now go over a few items so you know how to participate in today's webinar. We have taken a screenshot of an example of the attendee interface. You should see something that looks like this on your computer in the upper right corner. You're listening in using your computer's speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presentation by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the webinar presentation. Questions will, however, be addressed at the end of today's webinar. We are also recording today's webinar. Recordings will be made available at the end of WorkSafe Month on the WorkSafe Tasmania website. Also, at the close of today's webinar, you will receive a survey on the presentation. We do appreciate you providing us with your feedback. I would now like to introduce today's presenter, Professor Danielle Mazza, Head of Department of General Practice, School of Primary and Allied Healthcare, Faculty of Medicine, Nursing and Health Science from Monash University. Professor Mazza is an Australian leader in implementation research and knowledge translation in the general practice setting. She holds the Chair of General Practice at Monash University, where she has been Head of Department since 2010. Over the course of her career, Professor Mazza has made significant, sustained and ongoing contributions as a researcher and educator to advance general practice and primary healthcare in Australia in the field of compensable injury research and as a proponent of evidence-based quality improvements through guideline development and implementation. Professor Mazza led the development of the clinical guidelines for the diagnosis and management of work-related mental health conditions in general practice and is now leading a National Health and Medical Research Council partnership grant titled Implementing Work-Related Mental Health Conditions in General Practice, which is aimed at implementing these guidelines into practice. Prior to developing the clinical guidelines, Professor Mazza led the seminal research that illustrates the challenges faced by Australian GPs in providing healthcare for people with work-related injuries. Welcome, Professor Mazza.
Thanks very much, and hi everybody out there. It's always a little bit daunting speaking into the computer and knowing that there's everybody listening, and I hope that you'll get a lot out of the webinar today. And just to let you know, I've got a little bit of a cold, so hopefully that won't interrupt proceedings. Now, I'm just not sure how to click forward on the presentation. Okay, so are you going to click forward for me, Stephanie?
Yes, I could do that.
Okay, great, thank you. So thanks for the opportunity to talk about our new guideline for GPs on diagnosing and managing work-related mental health conditions in the general practice setting. Next slide. The aim of this webinar is to really introduce you to what is current best practice advice for consultations involving mental health conditions that have arisen or may have arisen as a result of work-related factors. And the objectives of this webinar are to describe the current clinical challenges that impact on the delivery of general practice care for work-related mental health conditions, to give you an overview of the scope of the guideline and illustrate to you how we hope the guideline recommendations can be applied in the practice setting. Thank you. Next slide. So what I hope to do over the next little while is to give you a background about work-related mental health conditions in general practice, an overview of the topics that the guideline actually addresses, and use a case study to illustrate some of the key recommendations. Thank you. So some of this information will not be new to you. Of all compensable injuries, work-related mental health conditions are the most expensive, the most difficult to diagnose and treat, and patients with these conditions have the longest duration on sick leave. According to workers' compensation claims data, workers with an accepted claim for a work-related mental health condition take 3 times longer to return to work than the median time for all claims. And we know that there's an association between poor mental health and long-term disability and being out of work. So for patients, getting them on the road to recovery sooner rather than later is really important. And GPs have a crucial role in the health care that these patients receive, because almost all injured workers seek care from their GP. And this might be at various stages in their mental health condition, early on during assessment and diagnosis, in assisting patients to select the most appropriate management strategy, and in the follow-up care for their condition. Not all patients with a work-related mental health condition will seek compensation for their injury. In fact, it's estimated that for each patient with a successful claim, there are 30 patients who will see their GP who either don't submit a claim or whose claim is unsuccessful. Often, patients seek advice and guidance from their GP about navigating the system. Patients say that GPs are one of the most trusted sources of advice. Next slide, please. We know that GPs face some challenges in dealing with these conditions when patients present. For instance, when asked to certify fitness for work, patients with a mental health condition are almost always certified as not being fit for any kind of work, whereas this only happens in 68% of the time for musculoskeletal conditions. So this raises a conundrum. Is this because patients are not really fit for work, or is it that the GP holds reservations about the implications for returning to work for the patient? In a study that we've done with GPs, injured patients, compensation agents and employers based in Victoria, we explored these issues, and all 4 groups consistently describe mental health conditions as complex. Clinical challenges faced by GPs included difficulties with the initial assessment and diagnosis related to the invisibility of the injury and establishing whether the mental health condition developed as a consequence of work, conflicting opinions about the causality and the severity, treatment and prognosis of the mental health condition, difficulty managing comorbid conditions such as opioid dependency that arose following physical injury, and uncertainty regarding predicting a return to work date and recommending alternative duties. Interestingly, when we looked internationally for advice that GPs could turn to, we found that there was no guidance for GPs internationally to advise them on how to address these clinical uncertainties. So we sought to develop national clinical guidelines for Australian GPs, and we wanted to make sure that these were relevant and useful. So we did a couple of things. We really had a very strong implementation focus. For instance, to define the scope of the guideline, we asked GPs and others to reflect on the points in the consultation that they found challenging and where they would reach for a guideline, and we turned these into the questions that the guideline actually addressed. And to make sure that the guideline was useful, we developed it to an NHMRC standard to reassure GPs that the recommendations are based upon the best possible evidence. And we sought endorsement from the RACGP and the Australian College of Rural and Remote Medicine to ensure that the recommendations were feasible and relevant for practice. The final thing to note is that we're very aligned with current national mental health policy, and the guideline is written in the context of the current policies around mental health best practice. So I urge you to become familiar with the following two statements: the Health Benefits of Good Work Consensus Statement and the 5th National Mental Health and Suicide Prevention Plan. Just stay on this slide, thank you. So the guideline is now available, and you can download a copy from our website or read the summary article that we published in the Medical Journal of Australia earlier this year. Next slide. So the guideline's been formatted to enable GPs to access the information rapidly. So it kind of mirrors what happens in clinical practice, and the topics are arranged in order from initial assessment and diagnosis, or identification of a comorbid condition, to management and considering if the patient can work, and finally follow-up. So it kind of flows through the order of the recommendations. The guidelines also presented in 3 formats. So we have a detailed guideline that describes the guideline development methods, a summary of the evidence, the detailed recommendations, and provides supporting information and resources to assist GPs to implement the recommendations. What you're looking at on the screen there is a GP summary, which is a 2-page document that provides the recommendations in an easily accessible format. And we also have a short form of the guideline that provides an overview of the methods undertaken and then lists the recommendations in full. So we've tried to cater for everybody's needs, from people who really want to see the detail and get access to the resources and the full information, to those who just want the very quick overview. Next slide, please. And the guideline, in terms of its scope, is intended to be used in the treatment of any person who presents to a GP with symptoms of a mental health condition that may have arisen as a result of work factors. So it's not necessarily just those patients who have an accepted claim. And the conditions that are addressed in the guideline include depression, anxiety, post-traumatic stress disorder, acute stress disorder, adjustment disorder, and substance use disorder. And the recommendations, as I've mentioned, build upon the Health Benefits of Good Work Consensus Statement and the 5th National Mental Health and Suicide Prevention Plan. Next slide, please. The guideline sets out 3 guiding principles. The first is that practitioners should understand their scope of practice and when it's best to refer. So it's important that the GP provides care that's within their expertise and their knowledge and capabilities, and is the optimal care option for the patient, but where necessary, that the GP feels confident in being able to refer on to other health practitioners or providers that can assist where the issues go beyond the scope of that particular GP, and that may vary for individual GPs. Second issue is around cultural considerations, and the GP should ensure that the patient receives culturally appropriate care throughout their recovery, and should work with the patient and other relevant providers to determine how best to provide this care. So we really became aware of this issue as critical in mental health and recovery for patients, that we be cognizant of culturally appropriate care. And we also became cognizant of the need to be concerned about the care of young people, and that the GP should ensure that young people receive appropriate care throughout their recovery, and should work with the patient and relevant others to determine how best to provide this care. So these principles really have one thing in common, which is really patient-centeredness, and we encourage GPs to keep their patients' needs and desires and concerns at the forefront of their decision-making and their assessment and their management throughout the care trajectory. Thank you. Next slide. So while the guideline addresses 10 clinical topics, we're really just going to work through several of these in this webinar. The guideline addresses 10 clinical topics, 4 on assessment and diagnosis and 6 on management and follow-up. And these were the 10 issues that in our study GPs wanted answered. So, is this a mental health condition? Is it a comorbid or secondary mental health condition? Has it arisen out of work as a result of work factors? What should the GP consider when conveying diagnosis to the patient? How can the condition be managed to improve personal recovery and return to work? Can the patient work in some capacity? What is appropriate communication with the patient's workplace? What strategies are effective at managing comorbid mental health conditions and substance misuse? Why isn't the mental health condition improving as expected? And what can a GP do for a patient whose mental health condition is not improving? So for the purpose of my presentation today, I'm going to focus on the topics that we think are most likely to influence current practice. Next slide, please. So let's put the guideline to work through a case study. And the case that I'd like to discuss with you today is one of Sue. And it's based on a real patient experience and interview that we conducted, but Sue's name is obviously a pseudonym. She's 43 years old and she is a social worker, and her work focuses on assisting youth to transition from residential care into the community. But she says that her work has been causing her to feel anxious and making her feel physically ill. She describes how over the past year her role has changed from one that was quite autonomous. She used to, for example, previously facilitate a peer support group, represent the organisation at regional meetings, and engage in training activities, but now her role has changed into a very task-oriented case manager position. And this change is causing her grief, and she started to have panic attacks on the way to work. She says it takes her only 5 minutes to get to work, but by the time she gets there, she's in a lather of sweat. She's really not coping, and she says she wants to resign from work, but she can't afford to financially, and she really doesn't know what else to do. So what would you do if Sue came to see you and told you this? She appears to have symptoms that are in line with an anxiety disorder. She talks about panic attacks, feeling a lather of sweat. She describes a specific trigger at work that seems to have initiated these issues, but also says that the triggers are continuing because she gets panic attacks on the way to work. And finally, she wants to leave this work. Does she mean the workplace, or is it the role in particular that she wants to leave? She can't leave because she needs the income, so she's continuing to expose herself to these triggers. And also think about what could happen if she stays in this role, or if the symptoms are not addressed. So these are all the thoughts that are going through your mind as Sue tells you her story and presents in your practice. And I think this case illustrates an ideal one where our guideline and the recommendations within it can be utilised. So what's the optimal way forward for Sue? Next slide, please. So the first issue is really to try and get the diagnosis right. And I guess, people present with different symptoms often, and one of the questions that the GPs that we have previously interviewed asked us was, what tools can assist in really diagnosing and managing, diagnosing and assessing the severity of the mental health conditions? So if you look at that, the recommendations that arise in our guideline, there's a very strong recommendation that that when you're considering the presence of anxiety, that you use the GAD-7 or the DAS scale to assist you with the diagnosis. So we can use either of these tools to assist us in determining if Sue has an anxiety disorder, and the GAD-7 especially to assess the severity of that anxiety disorder. While the DAS can't be used to really confirm the diagnosis or assess the severity because it has low specificity, the questions within the tool can be used to guide the clinical interview, and our guideline has links to these tools that can be utilised by GPs for this purpose. The second key message from this recommendation is to ensure that the assessment of the mental health condition is really appropriate, and that care is put in place is appropriate within the GP's expertise. Just of note here, we've referred to anxiety disorders as a broad category, and because the DSM-5 describes 13 different categories of anxiety disorders, so it's not practicable to expect GPs to be familiar with diagnosing each particular one of these disorders. It's also important here to note the two practice points. To use the tools alongside a comprehensive clinical assessment with consideration of cultural issues, and to seek advice from a specialist if you're experiencing difficulties in making a diagnosis. Next slide, please. One final point about the diagnosis is with regards to how the diagnosis is conveyed to the patient, so that it establishes a recovery-oriented approach to management. And some GPs might be familiar with the concept of developing a therapeutic alliance. And this is a dynamic process of ongoing trust and engagement between the clinician and the patient. And it's important that the GP builds this therapeutic alliance when the patient presents, and continues to build this alliance and work with it through treatment and recovery. It's equally important to note that maintaining this therapeutic alliance will involve sharing decisions with the patient and other health professionals who are involved in the patient care. And these include decisions about which medical professionals are going to be involved in the care, and communication with the patient's workplace. So very early on, from the time that the diagnosis is made with Sue, if you're using these tools to assist you in making that diagnosis, starting to work with Sue, that you really talk to her about recovery from the very start, and about how you plan to work with her in this kind of shared decision-making, patient-centered way to help her to achieve recovery right from the start. Next slide, please. So often in general practice, we have patients that come to see us that we've known for a long time, and many of these patients have had previous mental health conditions or previous traumas in their life. And GPs struggle with the issue of whether the mental health condition that they are being presented with has actually arisen as a result of work. And they asked us to try and help clarify this for them, and whether there was anything that could assist them in coming to this conclusion. And really, the evidence here was not very strong, and our guideline development group made a consensus-based recommendation that the assessment should be made on the basis of a comprehensive clinical assessment, consideration of the factors such as pressures, events or changes in the workplace, and the temporal relationship between these factors and symptom onset, and consideration as to whether the mental health condition is consistent with the description of how the condition arose. It's important to distinguish this from compensation liability. So while these suggestions that I've just outlined may help to determine whether the condition has arisen as a result of work, it's important to note that GPs don't assess whether the condition is subject to workers' compensation liability, and that can only be done by the workers' compensation authority. So in conclusion here, we didn't really find any tools that could assist a GP to make this consideration. But there were a couple of tools that were useful or relevant to assist in the clinical assessment, and these were the work environment scales or the workplace stresses assessment questionnaire, and they can be helpful in adding information in this setting. Secondly, the document Preventing Psychological Injury Under Work Health and Safety Laws by Safe Work Australia describes the range of psychological hazards that can be considered when thinking about whether a mental health condition has arisen out of work. And this includes a range of factors as listed on the slide here. High job demands where there's sustained high physical, mental or emotional effort required to do the job, or low job demands where there's little task variety or highly monotonous work, low job control autonomy where there's little control over aspects of the work, including how or when a job is done, poor support, with inadequate emotional, informational and instrumental support to do the work safely or well. Poor workplace relationships between workers and their managers, supervisors, co-workers and clients or other people the work is required to interact with. Low role clarity, where there's unclear, incompatible or constantly changing expectations about the role and responsibility. Poor organisational change management, where changes in the organisation, structure or job are poorly communicated and managed. Low recognition and reward, where there's lack of positive feedback and rewards for job and task performance. Poor organisational justice, there's perceived unfairness, inconsistency and bias in decisions about the work and the way workers are treated. Poor environmental conditions, rural and remote work or isolated work. All of these factors may contribute to mental health conditions arising from the workplace. And if you think about Sue, she states that her role had changed from something that was very autonomous and task-oriented to one where she felt low job control autonomy and, you know, feelings of injustice, poor organisational change management. So this change aligns with the chronological sequence that gave rise to the anxiety symptoms, and Sue's symptoms are consistent with the type of work stress that she describes. Next slide. So let's move on a couple of months, and you've instituted some management during this time. You've diagnosed Sue with an anxiety disorder. You've referred her to a psychiatrist, and she's been seeing the psychiatrist for 4 weeks. And after her initial appointment with you, Sue was off on leave for 2 weeks, but then went back to work. She spoke to her manager about how she was feeling and was advised by her manager to put in a work cover claim, which she did, and that was accepted. And she's now on leave from her work again, and she's come back to you for a review and a certificate. Next slide, please. So the question then becomes in the management, how can the condition be managed effectively to improve personal recovery or return to work? And again here, there wasn't very good evidence to support initiatives in this area, and our recommendations were really consensus-based from our group. And the key messages, I think, to derive here that it's part of the GP's role to keep a very patient-centred approach, building on that therapeutic alliance. So this involves developing a good understanding of the current management approach that Sue has agreed with the psychiatrist, and really to discuss and set realistic and positive expectations for recovery. And this may include ascertaining Sue's perceptions, beliefs and attitudes about her illness and her recovery, recalibrating some of her views, or explaining and discussing the treatment options and reviewing any ongoing environmental factors that may impede her recovery. And I think the other thing to note here is that we do have existing high quality clinical guidelines for the management of anxiety. We didn't want to kind of repeat the exercise of creating guidelines for each of the specific conditions. But in our guideline, we provide a list of and the links to guidelines that are out there, evidence-based guidelines for the management of the various mental health conditions, including anxiety, that the GP can utilise to assist in the management of these conditions. Next slide. And then the issue is whether or not Sue can return to her workplace and whether that is in some kind of modified capacity. We know that Sue's manager is supportive. She was able to talk to her manager about how she was feeling. And it may be that Sue can return to her workplace, possibly to perform alternate duties. So a GP would need to know what kind of duties are available to Sue in the workplace, and this would involve firstly identifying with Sue if there are patient or workplace factors inhibiting her from returning to work, having a detailed conversation with Sue's manager and receiving some written information about possible alternative duties, and discussing these duties with Sue before making a recommendation. Again, stressing the importance of that therapeutic alliance and making sure that that remained front and centre of your focus. You may also wish to collaborate with an occupational physician or a workplace rehabilitation counsellor to assist in making an educated assessment of the workplace environment. So you're now a few months further down the path with Sue. She hasn't yet returned to paid work, but she started some voluntary work at a local nursery so that she can interact with customers. She reports making mistakes and having some difficulty concentrating and getting nervous. If something goes wrong, she starts to panic. She's still seeing the psychiatrist who's reviewing her medications. She has a supportive husband. Her work is also supportive, and she meets with the manager for a catch-up every so often and with other colleagues for a coffee. But the question is here, next slide please, why hasn't this condition settled by now? What's going on here? We know that mental health conditions can take months or years to resolve, but continuing on new stresses may impede recovery. And it's important to be conscious of these when patients aren't improving as you thought that they might. And here really we had quite strong evidence with strong recommendations. And you need to think about what patient factors, what potential workplace factors, health behaviours and attitudes, or indeed other medical factors such as the ones listed on the slide here, may be actually impeding recovery, and work to try and address these. So when a GP's patient is not improving, what can the GP do? And here we have a couple of recommendations. The first is to investigate the existence of continuing work and non-work stresses, as we've just discussed. Also to review the diagnosis and treatment plan to optimise treatment and adopt a very patient-centred collaborative care approach involving all the relevant health professionals. And when no stresses are identified, but particularly where there's persistent depression, to really be collaborative in the care and use CBT as an adjunct to pharmacotherapy. Some key messages here are to focus on that patient-centeredness, reviewing the diagnosis and treatment plan, and really engage with the workplace to understand where the stresses are, and to really focus on the availability of alternative duties. Or indeed, you know, if there's stresses such as bullying or other issues, to seek some kind of independent remediation to negotiate changes to ensure a safe return to work. Next slide, please. So I hope that the case study that we've utilised has given you some indication of how the guideline can assist GPs to manage work-related mental health conditions and to introduce you to the current best practice advice for patients with these conditions. And I'd urge you to refer back to the guideline, which is available through the Monash University website, through Google, and also to that MJA article that I discussed earlier. Next slide, please. And I'd just like to finish by acknowledging the work of very many people and our partners involved in the creation of this guideline. As we mentioned earlier, it's been endorsed by the NHMRC, by the College of GPs and the College of Rural and Remote Medicine. It's actively being disseminated, and we're currently working through the Improve project to implement it into practice and scale it up, scale up that implementation around Australia. But happy at this point to take any questions. Thank you.
Thank you, Professor Mazza. So as Professor Mazza said, we will now answer any questions. Please submit your questions via the attendee questions pane in your control panel. So please take your time to submit your questions. And just to remind everybody, while those questions are coming through, there is still time to register for other WorkSafe Tasmania Month webinars and events. We have our final webinar occurring on Thursday, the 31st of October, which is the end of WorkSafe Month. And we have our final event tomorrow here in Launceston at the Albert Hall, the WorkSafe Expo. So if you are in Launceston and can get to the expo, we do encourage you to come along. So there haven't had any questions come through at this point in time, Professor Mazza. Is there anything else that you would like to add in respect to the clinical guideline?
No, I think just to use it as a useful resource that while GPs might be familiar with the two-page algorithm or summary, some examples of which we had in the slides of the webinar, the more detailed guideline has the links to all of the tools that we refer to and the additional resources, and that GPs might also find these very helpful to download and incorporate into their software so that they can pull them up when and if they need them.
Okay, thank you, Professor. So given that, thank you, Professor Mazza, for your presentation today, Clinical Guideline for Diagnosis and Management of Work-Related Mental Health Conditions. We appreciate your time. As I mentioned, there is still time to register for other WorkSafe Month webinars and events. Please head to worksafetasmonth.com.au. Also, at the close of today's webinar, you will receive a survey on the presentation, and we do appreciate your feedback. So on behalf of WorkSafe Tasmania and our presenter, Professor Danielle Mazza from Monash University, again, we appreciate your time, and thank you everyone for joining us today.
All right, thank you.